is branded as No Sugar November. No sugar November. Now, let me say that sugar is important because it acts as an electrolyte in the body. So we're not saying absolutely, but when we talk about sugar, we're merely talking about refined sugars. But many of the foods that we eat, the largest food group being carbohydrate, is laden with sugar, and so we will get sugar from that. But particularly the refined sugars, the white sugar, the brown sugar, we're saying let us avoid these sugars for the month of November. So I'm going to run through the calendar of activities that we have put together for the month of November. And it began with November 1 being our official press release. And the president of that association would have done so with the media. Today, we're having a panel discussion on health vibes relating to diabetes, and we have two experts that's going to be joining us subsequently. The 10th, the 9th and 10th, which is Saturday and Sunday coming, we will be having an official press release that is going to be read at all churches, as many churches as possible in Dominica, again sensitizing people on diabetes. So that will be read at most churches in Dominica, both Saturday and Sunday. On the 12th, that is, we're having a nutrition talk at schools, at some selected schools, and so a nutritionist will be there and will be sensitizing the pupils and students about good nutrition and some of the foods that are healthy and those that are not so healthy and those that may increase your risk to diabetes, particularly if they're consumed quite frequently and in large quantities. On the 14th, we are having our major press conference on the 14th, and that is going to be happening at Prevost Cinema Mall, and that is it's going to be live on most media. It's going to be broadcast, and so we expect you to listen to that press conference. And at the same time, too, there is going to be a diabetic retinopathy screening that is going to be done by Dr. our very own ophthalmologist consultant, Dr. Hazel Shillingford Ricketts. On the 15th, we're having a sidewalk health screening. It's almost like a mini fair whereby you can walk through and get the preliminary testings done, your blood pressure, your glucose, your BMI, your body fat percentage, a foot screening as well. So you could know whether you're losing sensitivity in your feet. And we'll also be examining to see if there are any foreign objects that may be in your feet, particularly if you're diabetic and you have severe nerve damage. You may not even know that something has pierced your feet. On the 16th, we're having a diabetic health clinic cardio jam that's going to be in the Portsmouth area. And so, if you are in the north of the island, we're asking you to join us on that day to really know your numbers, but more so, um, basically, be an advocate, a personal advocate, and to actually collaborate with us and make this health clinic a very big one. On the 17th of November, we're having an awareness walk and cardio jam. And that is happening in the Rosa area. We will have our truck, we'll have a generator, we'll have some good music, we'll have water, we'll have our t-shirts. It's similar to that of the cancer walk. And so this year, that's happening on a Sunday. We've recognized that the Sunday walk seem to be generating a bit more people because there are people who worship on a Saturday, the Adventists, and it's a bit difficult for them to participate when it's on a Saturday afternoon. And so this time around, we are doing this walk again on a Sunday, and we expect you to be in large numbers as we walk against diabetes. On the 20th, we're having a major panel discussion. Again, we'll be discussing matters relating to diabetes. And on the 27th, we are having some published diabetes stories whereby people who would have been affected by diabetes would share their own stories, their triumphs. Some people who would have gotten a diagnosis and reverse the diagnosis through lifestyle modifications. And so it's an entire calendar of activities. We will continuously share that calendar with you. We will make it available as the dates gets closer. As the dates get closer, we will basically let you know what are the upcoming events. My co-host is here in what color green is that? It's a particular green. Um,
Carlton, I don't know what green.
I don't know. No, it's not forest green. It's not as dark as that. But it's maybe an emerald green. I don't know if there's a color called emerald green.
Yeah.
It's a beautiful green. Green is my favorite color. And so when I think of green, I always think of hope. I always think of just that optimism that life goes on. And so Trudy, my co-host, is wearing my favorite color.
Is in
this
hope
morning.
and optimistic
Yes.
mood. Good morning, Carlton. Good morning, of course,
Good
to the
morning to you.
listeners of Q95 FM Radio. Carlton, it is the first day back at work after a long weekend, so I was struggling to leave my office this morning and joined you all a bit late, but of course happy to be here and happy to be back in the swing of things after the long independence holiday. So we're here. We're on Health Vibes.
We're here.
Yeah.
And I'm not too sure about you, but yes, the last night Rose was a rampart of people. And I said, I think Dominicans really looking forward to Carnival 2025. The number of people that were in Roseau last night, and I must say it was incidence free. And so that actually was a good thing. All right. So what we're going to do, we're going to take a short break and then we'll actually introduce our guests this morning. We have two specialists that's going to be joining us this morning. And as I said, our focus is going to be on diabetes this morning. Let's take a break.
Oh, and if they say convenience could make a big difference, then you can trust me. I know just where you should be. And that is JP Mega. The one-stop shopping, Dominica, nigga. You could be shopping and having fun with your daughter or with your son. We cater to everyone. What a happy place. Oh, JP Mega. The one-stop shopping, Dominica, nigga. You could be shopping and having fun. Bring Papa and Mama along. We cater to everyone. What a happy place. Oh, what a happy place. You just stick some more any item and you automatically qualify for a discount. Check us out at the Mega Store in Funkole where there's lots of parking. On Monday to Friday from 9 a.m. to 7 p.m. On Saturdays from 8 a.m. to 6 p.m. And on Sundays from 10 a.m. to 2 p.m. JP Mega, the best family shopping experience.
Introducing Jolly's Pharmacy, brand new website. www.jollies.gm. It's your time to jump the line. Shop now at jollies.gm and have your items delivered in the comfort of your office. No more standing in line. No need to use your lunch hour to shop. Hassle-free shopping, safe and secure. Jollies.gm features rush delivery, 1 hour. In-store pickup, regular delivery, 5 p.m. Cut-off time, 4 p.m. It's your time to jump the line. Visit us at www.jollies.gm. Jollies Pharmacy, leading the way in healthcare.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lango with co-hosts Jacinta Fagan-Defoe and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
Introducing Jollies Pharmacy, brand new website. www.jollies.gm. It's your time to jump the line. Shop now at jollies.gm and have your items delivered in the comfort of your office. No more standing in line. No need to use your lunch hour to shop. Hassle-free shopping. Safe and secure. Jollies.gm features rush delivery, 1 hour. In-store pickup, regular delivery, 5 p.m. Cut-off time, 4 p.m. It's your time to jump the line. Visit us at www.jollies.gm. Jollies Pharmacy, leading the way in healthcare. In healthcare.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lango with co-hosts Jacinta Fagan Defoe and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
So we're back with you this morning on Health Vibes, your very own health talk show, brought to you by the brand you trust the most, Jolly's Pharmacy. This morning, as I said, we are discussing diabetes, which is one of the chronic non-communicable diseases that's affecting not only Dominica, the world by extension. And what is even more disturbing about this medical condition is the complications that it causes. We know that it can cause strokes, it can cause amputations, it can cause blindness, it can cause I'm trying to remember some of the others, but there are many complications that are associated with diabetes. And this morning we are joined with our very own consultant, ophthalmologist, Dr. Hazel Shillingford Ricketts, and she's going to focus a little on diabetic retinopathy. I know she's been in practice for so many years, having done a lot of work in eye care, and I'm sure she has many, many stories that she can share with us as it relates to this particular complication from diabetes. Dr. Ricketts, good morning to you.
Good
Good
morning.
morning, Carlton. Good morning, Ms. Christian. Good morning to the listening public. It's nice to be back here after a long while.
Yes.
And today I'm going to talk about diabetic retinopathy, which is the complication of diabetes in the eye. I have brought this topic to the attention of the public many times before, but there's always good to have a reminder.
Mm-hmm.
Mm-hmm.
Definitely.
Yeah, so because diabetic retinopathy, which is the term for the complication in the eye, affects the blood vessels in the retina. The retina is the nerve lining inside the eyeball, and this is the nervous tissue that captures the images of what you see, so that the nerve of the eye can transmit the information to your brain for you to see. So it's like the film in a camera. If the film is not good, you don't get a good picture, no matter how sophisticated your camera is. And so that is the old time analog cameras. But yes, it is the leading cause of preventable blindness in the working population. So if you look at 20 to 74, this is the leading cause of preventable blindness. And it can be prevented, as the term says. So we have to do certain things to prevent the blindness from occurring. And so it is one of the top 3 leading causes of blindness in the world in any age group. So it is a significant public health problem, especially as we know the prevalence of diabetes is increasing
Yes.
with obesity, our lifestyle, our diets, and whatever it is. So we're going to be getting more of this complication. Not everybody with diabetes get that diabetic retinopathy. But if you go across the board at any one time, you will find 30% or 3 out of 10 diabetics will have diabetic retinopathy. Most of them will not know that they have it. So the only way they're going to know is to have their eyes examined regularly. Okay, because sometimes you can have vision threatening retinopathy and you don't know because of where it is located. So it is important to have screening regularly. And so,
Dr. Gates, I just have a little question here. You said not all diabetics will have that complication. 3 in 10 may have. Is it uncontrolled diabetes that's the risk for diabetic retinopathy, or is it just having the disease? I've always wondered when we talk about risk factors or complications, are we talking about in people with uncontrolled disease, or are people who have the disease controlled still at risk for those complications?
Or even adding to that, if you've been pre-diabetic or there is a strong family history of diabetes, but you may not necessarily be diagnosed as yet.
So that's a very good observation. There are indeed screening risk factors that makes you more susceptible to developing diabetic retinopathy. Because I have one of the first questions I ask patients who have diabetes, how long you have it, because duration of the disease is very important. Usually after 5 years for the type 1 diabetics, and for the type 2, at the time of diagnosis, they may have retinopathy. So the longer you have diabetes, is the greater the risk you will develop it. Also, if your blood sugar is not well controlled, if your blood pressure is not well controlled, if you have elevated cholesterol. I have seen patients with elevated cholesterol and they go on the anti-cholesterol medications or they change their diet and their retinopathy has regressed. Because when the blood vessels in the retina gets damaged, it becomes very leaky. So fluid, fat, blood gets leaked out into the retina, and depending on where it is, it can affect the vision. So if you look, we talk about the classifications of diabetic retinopathy. So one is non-proliferative. So you hear that term proliferative, which tells you that something grows, there is something proliferating in your eye. And when the retinopathy is affecting the eye, and the eye is, the blood vessels get closed off, the small blood vessels we call the capillaries, then you do not get enough oxygenated blood and nutrition going to the retina. And the retina tries to heal itself by growing new vessels. And that is where we call the proliferative type of diabetic retinopathy. So if you don't have the new vessels growing, it is called non-proliferative. If you have new vessels growing, it is called proliferative. But these vessels are very fragile, so they can burst on their own and cause massive hemorrhage in the eye, which cause you to lose the sight because of all the blood in the eye. Also, the non-proliferative one, if you have leakage occurring in the macula is the part of the retina responsible for seeing your sharpest vision. Then you get macular edema, and this is the most common cause of blurred vision from diabetic retinopathy. And so,
sorry, doctor. I just wanted to ask you, though, as well. So once someone has been diagnosed officially with diabetes, it is now should they be recommended as well to have their eyes screened? And is it one of the protocols that is there?
It is definitely one. If you have a list of things to do for your patients, you check their blood pressure, cholesterol, their food, you've got to send them immediately, especially the type 2 ones, because I have seen patients in my office with diabetic retinopathy and they don't know they're diabetics. And so yes, when a patient is diagnosed with diabetes, one of the schedules you've got to do for them is to have their eye examined. And this is actually the responsibility of the health worker, because the patient doesn't know anything about retinopathy or whatever it is. So you, the health worker, you have to refer them to an eye specialist or to screening for screening,
Mhm.
because we have several ways of checking the eyes or screening the eye. So we have the screening program, where in Dominica now we have 2 internationally certified screener graders in the hospital system, and they use a fundus camera to take pictures of the retina, and they are trained to grade the retinopathy that they see, and they refer to the eye specialist for further management. And so you screening or to see an eye specialist. Also, when you see, sometimes patients come just for their glasses, and in the history you find out they're diabetics, you just don't do the glasses prescription. You dilate their pupil and you look. So this is called opportunistic screening.
Mm.
Okay, you use the opportunity of they coming to see you to screen them for diabetic retinopathy. And so we were talking of how your vision is affected. So we say macular edema, vitreous hemorrhage, fractional retinal detachment. So these abnormal vessels can actually shrink and act as a rubber band to pull your retina out of place. That same abnormal vessels can grow in the drainage area of the eye and lead to what is called neovascular glaucoma. And this glaucoma is very painful, very high pressures, and it can cause you to go blind too. And so these are the different ways diabetes can affect the eye. But you can have other eye complaints that is not associated with diabetic retinopathy. And the most common one is blurred vision. So if the blood sugar is very high, this sugar actually oozes into the lens of your eye, and by osmosis, it draws water into the lens and causes the lens to swell, and that will make your vision goes blurred.
Wow.
So sometimes this is how patients present. All of a sudden they just cannot see as well, and you have to wait for 3 months after their blood sugar controls for the lens to get back to its pre-morbid state before you can prescribe glasses. And so also it predisposed to cataract formation. And the treatment for cataract is surgery. Okay, so this is another way that the diabetes can affect your eye. And so you also have the muscles that move your eye. It is supplied by small blood vessels, and these small blood vessels can be affected, that cause paralysis of those muscles, and so the person will end up with double vision or crooked eyes because the muscles cannot move to this is not a very common condition, but it is something that can occur. And if you control the diabetes, after about 6 weeks to 3 months, the muscles will start back moving normally. So a patient can present to you with double vision because their muscle is paralyzed, and it's because of the damage to the small blood vessels affecting that muscle in the eye. And so these are some of the ways that diabetes can affect the eye, not only by the retinopathy. And so we are going to we're talking about the risk factors, and I did not finish. So we said having diabetes for a long time, polycontrolled blood pressure, polycontrolled blood sugar, high cholesterol. But if you are also pregnant, so if you're diabetic and you become pregnant, it can exacerbate diabetic retinopathy. So a diabetic who is becoming pregnant, the protocol is that you check your eye before you even get pregnant. Because if you have retinopathy and you get pregnant, it will make it get worse. And you need to have the treatment placed to avoid you going blind. Because it's one thing to have a new baby and you cannot see. I've had that situation occur.
Wow.
Because sometimes if they have the abnormal vessels, when they push for labor, the vessels burst and they end up with hemorrhage in both eyes.
Wow.
That happened to my mother.
Okay.
Not my mother, but my mother's mother. Yeah, so my mother's mother, when she delivered her, she became paralyzed and blind in the time. So my mother never took care of her pussy.
Wow.
Now, pregnancy, so we said pregnancy. Now, if you have gestational diabetes, which is becoming diabetic while you're pregnant, it's also good to have the eyes checked, because sometimes these patients may have been a latent diabetic, they don't know, and it's only during pregnancy it is discovered. So they may have retinopathy too. So once you're pregnant and you have any, poorly controlled blood sugar, also you're diabetic, you should have your eyes
I wanted to ask you a
examined.
question, doctor.
Just let me do it first.
Okay.
Tobacco use, smoking. So if you're diabetic and you're smoking, that is a risk factor for making you develop diabetic retinopathy faster. And also our ethnicity, Black, Hispanic, American Indians. So if you're Black, you're at increased risk of not only developing diabetic retinopathy, but becoming blind as a result of it. So it is even more important for Black people, if they're diabetic, to check
To
their
screen.
eyes.
I wanted to ask you in reference to screening, because there are many service providers. There are some on the island, and they advertise screening. Who should you really go to? Is it the optometrist or the ophthalmologist for that type of screening?
So for screening, we have a specific screening program you can sign up with, like your nurses can send you to make an appointment. Or if you have your regular eye specialist, you can go to them, because they're all trained to identify
Okay.
diabetic retinopathy. And so whichever one is more convenient for you.
Okay.
The important thing is going to have, and your healthcare provider should ensure. So they should every year take out, have you had your eyes examined for the year? Because it is their responsibility to ensure. But it's also important for the patients to keep their appointments, because sometimes they are referred and they don't come. So like patients come, I say, oh yes, my doctor told me years ago to go check my eyes, but my eye was seeing okay, so I didn't come. And so not only is the responsibility of the healthcare provider to refer you, but you, the patient, have a responsibility to go to have your eyes screened. And so
I wanted to ask you another question as well in reference to medication adherence and its role in the control of diabetic retinopathy. You may have, as a doctor, you would have prescribed medicines for people, eye drops and so forth. How important is that in terms of adhering to the medication, consistently using it, having your reviews in terms of preventing further complications?
Well, it's funny because under treatment of diabetic retinopathy, the first thing is control of your blood sugar. So it means taking your medication regularly and following up with your doctors. And so, because I've had situations, and it's something that can happen. A patient may come and they're poorly controlled, and then you just pour medication into them for rapid control. That rapid control of the blood sugar will precipitate diabetic retinopathy. So if you have a poorly controlled diabetic and you are very aggressively treating them to get their blood sugar control and their blood pressure, at that time they should be monitored by the ophthalmologist, because that sudden control in the blood sugar can exacerbate the complications in the eye. Okay, so it is.
Wow.
You have to work hand in hand. A matter of fact, the eye is the only organ in the body that you can see the blood vessels in a live person. Okay, so it tells you what is happening in the rest of the body. So when you have retinopathy, the complication is not only in your eye. It is telling you that you have it in your heart, in your kidneys, in your foot, in your brain. And so that's why I have a stamp in my office. When patients come and they're diabetics, I either stamp their book or I stamp a prescription, and I tick off what grade of retinopathy they have. And they have to take it back to their doctor. So if the doctor sees that this person have proliferative diabetic retinopathy, more than likely that patient is going to have some form of kidney problem, some form of food problem, or so. So it is a way of feeding back to the to the
Management.
health caregiver that, hey, something is happening in the eye, so it's happening in the rest of the body. Let me be more vigilant in checking the other organs also. So this is a schedule that I am. So as I said, the first treatment of the eye problem is control, blood
Of the blood
sugar,
glucose.
blood pressure, cholesterol. Then the next form is regular screening. Every 1 to 2 years, you have to go and have your eyes screened. So even if you go 1 year and they tell you everything is okay, you must go the other next year, because you don't know when it will start. And unless the eye is examined, you cannot determine the and as we're on screening, as I said before, the type 2 diabetics, they are sent for their eye examination at the time the diagnosis is made. The type 1, which is usually in the younger age group, they after 5 years of disease, because it is such an acute onset disease, you will not see the complications for another 5 years in the eye. In children, the complications usually start at puberty, so you send them for their eye screening at puberty. Then you have those young people that have the metabolic disease, so they're not insulin dependent. They are treated like a type 2. So the people with the metabolic disease, once the diagnosis is made, they are sent to have their eyes checked, and they are managed like a type 2 diabetic, although they may be younger, than 30 when the diagnosis of juvenile diabetes comes on, and so, but it's a whole group of problems they may have that make them being considered. Now, one of the things that is done in the management is when the screening is done, you just don't tell the patient, okay, go. Whoever is examining the eye, if it is a screener, grader, or the doctor, they've got to counsel the patient then. You show them the pictures and you said, look, you see this blood vessel there, you see these white spots there, this is what that means, so they can appreciate for themselves how their eye is affected, even if their vision is normal. So you counsel them on the importance of regular screening and follow-up and going back to their doctor and keeping their blood sugar controlled. And so other form of treatment by the ophthalmologist, just be observation. So if you have a couple hemorrhages that is not affecting your vision, no treatment will be implemented in terms from the ophthalmologist's point of view. They tell you, okay, you have mild non-proliferative diabetic retinopathy, come back in 6 months, come back in a year. If, however, the level of retinopathy reaches the threshold for treatment, then treatment will be implemented. And the type of treatment we do is laser treatment, which is a specific wavelength of light that is used to burn the damaged area of the retina, which act as a stimulus for this diabetic retinopathy to get worse. Or we give intravitreal injections of anti-VEGF, which is to close off the leaking vessels and the abnormal vessels growing. But the laser and the anti-VEGF injection is not usually a one-time treatment. The laser, you might need 1 or 2 or 3 sessions. So the patient also have to be aware that I had laser, but it doesn't mean that everything is
okay.
You have to come back, first of all, to see how the disease is responding to the treatment. It may have regressed completely and you don't need more, or it may not have regressed sufficiently and you have to go back and do some more laser. So it is not a one-time treatment, and they have to be aware of that, especially with the injection. Sometimes you may need 5-6 injections at a monthly interval in your eyeball. And so patients usually squirmish when you tell them you've got to stick a needle in their eyes. Sitting in the chair, there you give the injection is like a 0.05 mil of, so it's a very small portion of the injection you give, and then you see them back in 1 month, and if they need more, you give them more. And so this, then if you have the eyeball full of blood, or you have the scar tissue pulling on the retina, they need to do what is called vitrectomy, where you go in the eye and you cut and clean away the hemorrhage and the scar tissue. And this we cannot do in the umbilical. We refer to Trinidad. But I have to say that I don't know if it's because we are picking up the disease earlier and treating with the laser and injection. I have not had to send patients to Trinidad for vitrectomy as frequently as I used to do before. So I think we intervening earlier and preventing them from reaching. I saw a lady recently, and I did her laser for her 20 years ago, and her vision is still good 2020 walking around, you know.
Wow.
And so then she came back complaining of floaters, and then she had some fresh hemorrhage. I have to go back and top her up with laser. But for 20 years, she had
was
her
good.
laser and she was doing good. So, you know, it is important that, you know, you have, it is not a one-stop shop. It's a continual follow-up and communicating with the health provider, you know, and so.
Look, I have two questions. I let me see if I can take one. My first is about diagnosis. You have indicated upon diagnosis, the healthcare provider should tell the patient, you know, you need to be screened every 1 to 2 years or so on, put them on a schedule. I know diagnosis itself may not happen easily. I know of a lot of people going into health facilities, having blood glucose tests done, and coming back saying, "No, I have a touch of my sugar is high, but you know, it's maybe ice cream I ate," and then they'll go another time and they'll say, "I maybe have a touch of," you know, but they're not ever diagnosed. But they just keep saying the sugar was high. You know, I know of a lot of cases like that. The nurse said the sugar was high. Maybe I need to drink more water, and then that's it. So my thing is, in situations like that where diagnosis hasn't been made, but some of the indicators have shown that the blood glucose is high and it has been consistently high, but the person hasn't been told you are a diabetic. How can we catch that in terms of screening for complications when there is no strong diagnosis being made by anybody, because the person is going here, there, getting high blood glucose readings, but not getting any solid diagnosis?
No, so there is a standard way of making the diagnosis of diabetes. So if your blood sugar in fasting is higher than 130, you're diabetic. So you may choose to manage the patient conservatively, where you send them for diet and exercise and monitor if they can control it. But once the sugar is high, and if after you eat it is greater than 180, you are diabetic. So it's not a touch of diabetes. Once your sugar is in those numerical
ranges,
range,
yeah.
you are it's not a touch. You have no touch of diabetes.
But you know, people say that though.
There is
People
nothing
say
like
that.
a touch of diabetes. You have diabetes. They may choose to, as I said, manage you conservatively because it is not very high, like 200-300. They may say, well, okay, go home, exercise, watch your diet, and come back. Let us see. Because some people, they do that and their blood sugar goes back to normal. Okay. But they still have to be monitored.
That's true.
They still have to be monitored.
I see so much of that. Maybe, yes, it's conservative management, but the person hasn't been told definitively. So they just feel like it's okay.
No, they're diabetic. They're diabetic.
I don't know. I guess it's also people are scared of the term diabetes. You know, so sometimes
they call it glucose intolerance, but you know, it causes the same damage. It causes the same damage. So these people should be placed on the same management schedule. And so,
okay. My other question was for you to guide us through what happens when you come and screen, because for somebody who has never done a screening, what is when they come into the office, what is the procedure specifically? I know you spoke of dilation of the pupil, but how does it feel? What do they get done? What can they expect?
Okay. So the first thing you do, you check the vision of the patient and the eye pressure. and it's in my office, and I in the screener graders, they do their visual acuity. Then you dilate the pupil, which is a drop that you put to make the pupil bigger, and it takes about half an hour after you put the drop for the pupil to be fully dilated. And then once you come in with the screener graders, they use a camera with a flash to take pictures in your eye, and they may take several shots of one eye at different angles. Okay, and once that is done for both eyes, then it is a digital. It will show up on the monitor of the camera, or if it is attached to a laptop or a computer, they will show you what the screening has discovered for you. And so in my office, for the opportunistic screening, we don't use a camera. We dilate the pupil, and then we use the slit lamp, which is like a microscope, with a lens, and we look at the retina to see what is happening. And now there is a even more advanced machine that we use now. It is called OCT, or optical coherence tomography. It is like a little CT scan, and it does a cross-sectional photo of the retina. So if the macula has some hemorrhages around it and you're not sure if it is swollen, you can use the OCT, and it will show you the thickness of the retina. It will actually measure it in microns. So 400 microns or 250 microns, usually about 250 microns is okay. Once it starts going up to 400 microns, you know that there is swelling there, and you can actually see the elevation of the retina and the little pockets of fluid underneath the retinal layer. And so this is a new form of investigation that we use, because especially for patients undergoing intravitreal injections, you can use this OCT to show you the response. So if they're getting better, the swelling of the retina will get less, and you will see the measurement getting smaller, and you know it is working. Sometimes you give 5-6 injections and the OCT shows that there is no change, then you just abandon that form of treatment. But yes, so, and we have one at the hospital, and I have one in my office. I think Dr. Lawrence has one. It's a very expensive machine, but it gives us a more accurate way of monitoring what is happening.
Okay.
All right. So I think many of you were glued and have been really listening attentively to Dr. Ricky. It's really talking on diabetic retinopathy, what you need to know, how to protect your eye, particularly if you're diabetic. If you have not had a screening done, it is important to have your glucose level checked, and not just by a random blood sugar, meaning somebody just poke you by the roadside and you just satisfy with that reading, but there are more quantitative analysis that can be done. You can do your insulin resistant test, you can do HbA1c, that you can find confirmatively whether you're diabetic or not. We have Dr. Dupe on. What we're going to do, we're going to take a short break, and then we will link with Dr. Dupe. Just stay on, please.
Say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lango, with co-hosts Jacinta Fagan Defoe and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
I woke up this morning feeling real stink. I had temptations to call it sick, but I end up in Jolly's Pharmacy. And down in the street, Jolly's fix up my immune system. Me feeling fit and strong, now I'm ready to work and make on any mission. If you see me again, Jolly's Pharmacy is number one. Jolly's working. We cater for everyone. Jolly's working. Boost up your immune system. Jolly's working. Yo, Dominica, it's your boy Father Box. Whenever I'm in town and I'm feeling down, I head to Jolly's Pharmacy. They boost me up real quick. Jolly's Pharmacy, leading the way in healthcare.
Cough, cold, sore throat, getting you down? Get Fitzroy Mentholated Cough and Cold Syrup for the symptomatic relief of cough, colds, catarrh, and sore throats. Fitzroy Cough and Cold instantly release and can be taken every 2 hours. It is pleasant tasting and competitively priced. Fitzroy Cough and Cold is manufactured in England. Fitzroy Cough and Cold, the relief you're looking for.
Distributed by Jolly's Pharmacy Limited.
So we're back with you on Health Vibes this morning. It's 8 minutes after the hour of 11. This morning we have a packed panel. We just heard from one expert, the eye expert. We're now going to connect with Dr. Corinthia Dupie, who is a pathologist by profession, and she's in Barbados. Dr. Dupie, good morning.
Good morning, everybody. Good morning, Orlando.
Dr. Dupie, good morning.
Good morning, Mr. Orlando. Good morning.
How are you doing
everybody.
today?
I am well, thank you.
Awesome.
A little shaky, I guess. I've never done this.
You've never done this.
Never.
Well, we welcome. We again thank God for technology that we can connect with you from Barbados. I know that you're one of the technical people, just like Dr. Ricketts. Helping us on the association, the Dominica Diabetes Association, and as a pathologist, particularly, one of the areas that I really wanted you to focus on this morning is wound management, and particularly how do we advise our patients, particularly those who are diabetic, to protect their limbs, their feet. We know of amputations as one of the major complications of uncontrolled diabetes, and we've seen a slight reduction in amputations in Dominica, but it is still a major cause of concern.
Okay, so I'm not involved too closely with the management of the disease, but I do see a number of situations where diabetes has reached an end point in terms of causing organ complications.
Mm-hmm.
I have to say also at the onset that diabetes isn't a simple disease as indicated by the main marker, which is elevated blood sugar or hypoglycemia, although that is a common pathway. So there are several mechanisms by which a person may become diabetic. And so although the management mostly focuses on keeping the blood sugar down, it is also important to know how exactly the disease begins, especially with the type 2 diabetes,
Mm-hmm.
because type 2 diabetes isn't necessarily caused by lack of the beta cells in the pancreas, but it can be triggered by several lifestyle factors, and I suspect that some of them have already been referred to, highlighted. So, like for example, dyslipidemia, that would be abnormal fat metabolism. Obesity can actually trigger the beta cell dysfunction. And as well, it could be that the problem isn't at all with the pancreas, but it is with the transporters of the glucose or the receptors of the insulin on the muscle or wherever glucose is absorbed in the body. So even though we are focusing on controlling the blood sugar, we should stress as well the lifestyle changes that need to be made. And so if we begin initially with the lifestyle changes, we can affect we can actually change the number of people who can be affected or who will be affected by diabetes, because type 2 diabetes is about 90% of cases worldwide. Having said that, the way the body manages glucose is to use it for energy. If the insulin if the insulin receptors aren't functioning and glucose can't enter the cell, and you have all that extra glucose, I heard Dr. Ricketts, Sherford Ricketts, refer to what some of the excess sugar can do. The excess glucose becomes converted into a toxic substance that is known as sorbitol. And when these sorbitol levels become extreme, they're going to cause, for example, the lens to swell. They're going to cause the lens to become opaque, and you're going to end up with cataract. And as well, it's going to affect all the micro vessels, blood vessels, the small blood vessels. And I'm sure she has highlighted that the retina is full of small blood vessels. The kidney, the heart, you have small blood vessels everywhere. But it so happens that the retina and the kidney, they don't have the necessary requirements to break down the sorbitol as most of our other organs do. And so they are the main ones that are affected, the kidney and the retina. However, the nerves also going to have that same problem, because the micro vessels that supply the nerves are also going to become poisoned, so to speak, by the sorbitol. And so you're going to end up with neuropathy. And because of the neuropathy, a number of diabetics are going to end up with injured feet, and they're not going to be aware of the level of the injury. So several diabetics may, for example, people that I know, end up getting probably a scratch on their leg going over a fence, and for everybody else, it's a small scratch, and most people will feel whether it's causing pain or not and give it some attention. A diabetic would probably not even feel that they've actually injured their feet, and so they will ignore it, and by the time they touch themselves, so to speak, the leg has become infected, because on top of the fact that there's the neuropathy and they're not appreciating the pain levels like the rest of us, they also have what we call in pathology, they have lazy leukocytes. They have white blood cells that are not functioning at full capacity. And so in a normal person, when there is any injury, you have the tissues are bathed with blood, there's swelling, and you have an influx of white blood cells that are going to manage the injury and set about repairing. When with the lazy leukocyte syndrome, you don't have that effective repair, and so they will develop an abscess, they will develop infection that's tracking along the tissues. So what looks like a 1 centimeter lesion, when the surgeons begin to tear the tissue away, the whole foot may be necrotic, and entire all of the tissues may be rotted because of the ineffective function, or because of the ineffective function of the white blood cells that are supposed to fight infection. And so I go into details of all the diabetic neuropathy because I'm not a surgeon and I don't see it. But I work in a country that is known as the capital, the amputation capital of the world, probably. because
Wow.
there is so much diabetes, and amputations are very, very frequent. And with amputations come the other problems, the mobility problems, and of course,
Depression.
patients that are bedridden are at higher risk of other pathologies. Pneumonia, for example, a bedridden patient is much more common than in somebody who's up and about and comes in contact with the same bacteria. There's also the risk of deep venous thrombosis in the remaining leg because this patient is lying in bed and there isn't much muscle movement. And so what we see is a multiplication of pathologies resulting from what somebody may recognize simply as a diabetic foot or diabetic ulcer. There comes the amputation and there comes the other pathologies. So most of the post-amputation deaths that I see are caused by pulmonary embolism, complicating deep venous thrombosis, or pneumonia from bedridden patients.
Dr. Dupe, I wanted to ask you a question quickly, though. In reference, there seemed to be a collaboration or almost like a link right now from most literature with diabetes and hyperlipidemia. If someone is diabetic, they are more likely to have high cholesterol, and vice versa. If you have high cholesterol, you are more likely to become diabetic at some point. Can you just maybe sensitize us a little on that?
I think that the hyperlipidemia or lipidemia tends to come first, but because the situation is complex, generally a patient with hyperlipidemia has also other metabolic problems, for example, hypertension and obesity. And because those things share almost like a common pathway, resulting in heightened inflammation. The inflammation, the stress on the body resulting from inflammation can affect the pancreas significantly. So that can be the link between the hyperglycemia and the diabetes. Sometimes it's actually excess fat deposition in the peripheral tissues, like we talk in the muscles, for example, that blocks the uptake of glucose from the insulin receptor, and so that lipid problem will secondarily result in diabetes. So even if the pancreas is functioning at high capacity, because the glucose can't be absorbed into the cell, because the insulin receptor has been knocked out by the hyperlipidemia, then you have that complication, and insulin is going to build up, and in response, the pancreas is going to be putting out excess insulin because it's really trying to take care of the glucose problem. And so after a time, the pancreas is going to, quote unquote, wear out because it's responding to that. So the problem may begin with the dyslipidemia and not necessarily diabetes leading to the hyperlipidemia.
Okay. Dr. Dupe, I know we have limited time, but I just wanted you to maybe just give. There are many people. I remember a couple of years ago, I was doing some corporate screening, and there was a gentleman whose glucose level was so high that the machine couldn't even read it, and we had to convince him to go to the hospital, and he was so reluctant. And I must tell you, sad to say that when we returned to that company, he was bodied off because he lost his leg. And this was someone who was nursing a bad toe for quite some time at home with typical OTC antibiotic ointments and so forth, and felt, well, he was doing something good. We see this situation happening quite a lot, particularly with our men who may, ignore the telltale signs that it might be something deeper than just this little wound. What advice would you give to people who may be in a situation like that?
Well, it's good that we're doing what we're doing at the moment. We can never stop educating the public. I think we need to use every opportunity for educational instructions or educating the public as much as possible. So hopefully all of the things that we've said here today will encourage people who are diabetic or at high risk for diabetes to not ignore anything that shows up, especially on their feet. So we're hoping that, because we know in most cases it's men, they ignore it, they're very strong, they're workers, they've dealt with things like that before, maybe when they were young, not realizing that now they're at a different stage in life, and the things that they could fight when they were young, they can no longer deal with. So we hope that we can continue all of these educational programs, and that the people listening will realize that a diabetic foot is a very serious problem, and they can end up losing the problem. People burn their feet sometimes, you're fine and something falls on your foot, and most people are going to ignore it, and in healthy people, it will go away. But with the diabetic, they have to pay attention as soon as possible, and they have to avoid things like hot food baths, for example, because of their neuropathy, they're not able to fully appreciate how hot the water is. So all of those are problems that we've seen occurring in diabetics, and we'd like them to just be more aware of how they take care of it.
Thank you so much, Dr. DOP. We truly appreciate you connecting with us on this busy Wednesday morning. We do hope that you'll be able to continue contributing on Health Vibes, and now that we have your number, that we can link up with you from time to time.
Sure. Good morning, John.
All right. Thank you again for contributing. Have a good day.
You're very welcome.
All right. Thank you so much.
Yes. Carlton, just wanted to make a few comments as we wrap up. When I was at the hospital, I used to see many amputees, or I know they have a number of patients on dialysis. And these are patients we don't see in the eye clinic. So if you're amputee and you're on dialysis, more than likely your eye will be affected. And so these people should really be referred. I mean, before I left, I had implemented a program where the nurse who does the screening at the hospital, she goes through the wards and gets the names of the diabetics who are inpatients and schedule them to come in while they are inpatients to have their eye screened. And so it's a way of the healthcare worker being proactive in going out and get these patients who are definitely high risk. The other thing we do, I think Ms. Chris did mention about hemoglobin A1C, is a way of estimating the glucose control for the previous couple months. But we have to know, as Black people, a number of us have a sickle cell trait or sickle cell disease. And the hemoglobin A1C actually measures the amount of glucose attached to hemoglobin A. So if you have hemoglobin AS, which is one normal hemoglobin and one sickle hemoglobin, your A1C is going to be normal because you're only measuring half of the full quota of hemoglobin, glycosylated hemoglobin. So in these patients, I always do a hemoglobin electrophoresis first to know if they have hemoglobin AA, which is normal, or hemoglobin AC or SC or so, because as you know, I can accurately interpret the hemoglobin A1C. Now, if they have an abnormal hemoglobin, then there is another test called fructosamine, and it measures the amount of glucose attached to a protein in the blood, and it gives you, and it is independent of the hemoglobin A, and it gives you the average level of glucose for the last 2 to 3 weeks. Is not as a long one as the hemoglobin A1C, but at least it is more accurate because it is not depending on the hemoglobin, which may be reduced because you have an abnormal hemoglobin. So these are practices that the healthcare workers should put in place, because I have a friend who boasts to me all the time, her hemoglobin A1C is always normal. And then when we checked, I said, but the way she was, her regular blood sugar was high, but her hemoglobin A1C was always normal. And then when we checked, she had hemoglobin AC. So half of her hemoglobin was A, which is the normal one. The other one was C. So when you're doing the hemoglobin A1C, it is only measuring the half of the hemoglobin A in the blood.
It's very interesting.
I never knew that.
Yeah.
So
Very
that
interesting.
is
Mhm.
because when you made mention of that, I was wondering whether many of your colleagues are aware of that and would do the other preliminary tests as well.
I know some of them do, and it's something I try to bring to their attention. But I know when I am requesting investigations, I always do the hemoglobin electrophoresis before I start monitoring the hemoglobin A1C.
Mhm.
A lot of sense.
And you see, and that's why it's important to know the population you're dealing with,
Mhm.
because
Exactly.
so so
Exactly.
what might be prescribed in a particular population is not necessarily what is for our population, which is predominantly black people. So that's a very interesting consideration, Carlton, and I have never heard I've never heard of that particular route of testing. That's very, very interesting. Carlton, I know we didn't get a chance to take calls this morning, but we did have some questions coming in on the Facebook Live. Somebody did ask as it related to diet, if there were any comments on that. And then somebody asked about the fee for the eye screening or consultation, as it is said. So I wanted to take those two, but I know we typically, Carlton, would have people who would be calling and asking questions,
Yes.
but we've had such a packed program this morning, we didn't get that chance. But Dr. Ricketts, if you wanted to comment on the consultation or the screening cost, as the person asked, and I don't know, a comment on diet. I guess the person
But we have somebody else
to come in. Okay,
on
yes,
diet.
because we're doing in 2 weeks.
Yes.
Okay, all right.
So Dominica was fortunate in terms of, in 2005, I established the Funders Photography Screening Program, and it was the first in the region. Nobody else in the region was doing that. And it is still going on. As I said, we have 2 screener graders that were internationally certified. So the ideal setup was, one is based at the hospital, so you can just go in and schedule to have your fundus photos done free of charge, or you can have your family nurse practitioner or your DMO refer you to have that screening. The other one goes through the health centers, all through the health centers in the 6 health districts, because Roseau goes to the hospital. And so you can just schedule with your nurse when next the screener grader is coming to their clinic, so that you can come in then. For November, where we observe Diabetes Month, in my office, I'll be having screenings on the 14th, 21st, and 28th, and it is free of charge. And the DOMDA has tickets to give to clients, and we prefer to choose. If you normally have your screening done every year, then you wouldn't benefit from that. But for those who haven't had screening for 2 years, or they've had amputations or dialysis, or they're poorly controlled, these are the high-risk ones that we'd like to give priority. And we plan to screen about 84 patients in these 3 weeks, and this is completely free of charge. If you come in as a regular eye patient where you're going to be screened opportunistically, then you will pay for the usual
Yes.
visit and so. But for this month, we have a free fundus photos at my office to just be part of, to contribute to the calendar of events of Domda. So they get the ticket and then they come to my office to make the appointment. And what are they expected to find to do there when they come? I will do their vision test, not for glasses, just check how well they see now. Do their eye pressure, dilate them, and do a photo of the eye. And I will be there. The technician will do the photo, but I am in the office, so I will look at it at the same time and explain to the patient what is going on in their eye. And if they need treatment or if they need follow-up appointment, then they can either schedule to be seen in my office, or if they want me to refer them to the hospital where they can get it free of charge. The option is theirs. But the objective really is to start the ball rolling.
And we applaud you for this gift back to humanity. Again, you heard Doctor said it's free of charge on those dates. It's a special gift that she's giving back to patients, ensuring that you are screened and you know if you are developing a complication or complications of the eye.
And just one more thing, the screening program is so important. Not only we pick up patients with diabetic retinopathy, but if they've got cataracts, if they've got glaucoma. So sometimes the 65% of the patients screened are referred for non-diabetic eye problems, because through the photography, we detect other problems in the eye. So it is a good way also of, checking your eye and your health of your eye too.
Dr. Ricketts, we're just about out of time. I just want to give some closing remarks as we wrap up.
Well, I'm very happy to be a member of Domda and to work with them to enhance care of diabetics. And so it is not nice that a working person gets blind because of diabetes when that can be prevented. So I have to commend Domda, and I would like the listening public to take note of the information that you're receiving today and in other sessions like this, and work on it to help yourself, to prevent yourself from getting blind. And my office is always open to provide care for patients who need it. Thank you.
Thank you, Doctor.
Again, Dr. Diopie from Barbados, we want to thank you again for connecting with us this morning. Dr. Ricketts, as always, awesome presentation. And to all of our listeners, we really want to thank you for being so attentive. And I know many of you, we have those who have the exercise book,
Yes,
who take notes,
constant
and
listeners.
you take notes.
We also have health professionals listening to us. I
As
see
well.
Dr. Johnson is commending us this morning. He's locked on to the program. So yes, our listeners, I think, got a good program today with a lot of information, and I learned a lot as well. So my brain has been ticking throughout the program.
Definitely. So week after, we'll be having part 2 of this. We'll be having the endocrinologist and also consultant nutritionist as well. That's going to be on in the next week and a half.
Yes, so not next week, but the
week
following
right,
week.
That's it. So from all of us here at the studios of QFM, as always, your health is indeed your greatest resource. Preserve it. Have a good morning, everybody, and continue enjoying the rest of your week. Bye-bye. See you next time.
Bye-bye.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30.